I'd like to welcome everyone to the first in a web series with the Society of International Urology, talking about COVID-19 from east to west, learning through the eyes of urologists. This first session is going to be discussing primarily the economic and financial burden of COVID-19. This program was thought of after a survey sent out to SIU members asking what they wanted to learn about COVID-19 and how we could try and help them through this pandemic. There's various topics that are going to be discussed. This first session is on the economic impact. We will also have topics on PPE, testing capabilities, treatments, prioritizing surgical procedures, and then managing urologic oncology patients. Those other series are to come. So I'll be moderating the session. Jack Zuckerman from Virginia in the United States. We also have a distinguished panel of experts. Xavier Catanliu from France. Sorry, I'm sure I botched the pronunciation. Gary Kirsh from Ohio in the United States. Stacy Loeb from New York City. And Francisco Montorsi from Italy. So I'll let some of the participants have prepared some slides to get the discussion going. So we'll start with Dr. Kirsch's slides.
Well, thank you very much, Jack. It's a great honor to participate in this program at this very difficult time. It's very interesting how vastly different the experiences are of the folks on the panel, as we'll come to learn through the course of the program. In my first slide, before discussing the financial impact, which has been significant, I just thought I would mention the public health impact on urologists and our employees. And as many of you know, for reasons that I'm not qualified to comment on, in the United States, mortality rates seem to be lower than in other countries. And as I think everyone in the world is aware, in the United States, the problem that we have from coronavirus from a health standpoint is widely variable by geography. Obviously, New York is the worst, and we've been discussing a little bit ahead of time with Dr. Loeb, who is yet to come on this presentation, and she can certainly attest to New York's situation. I don't know about New York, and I'll be interested to hear what Stacy says. Other than New York, I've only heard anecdotally of minor adverse health impacts on urology providers or their staffs. So at least in our area, and I think most areas in the United States, from the ability of us to deliver care with respect to the urology workforce, I don't believe it's been affected in most cases. The exception could be New York, and I would let Dr. Loeb comment on that later. In terms of the financial impact of COVID on urology providers, I would submit that this has been a unique crisis in healthcare and for urology. The United States has, in the last couple decades, has gone through a couple of other significant financial crises, 9/11 in 2001 and the 2008 financial crisis, which was somewhat of a worldwide financial crisis. In those cases in the United States, due to the fact that most of our compensation is provided by third-party payers, whether they be commercial insurance payers or the government as a payer, we really didn't see our revenues affected in those crises. This has been a unique crisis because we've been told that we have to shut down and not operate our businesses. So we've had no revenue coming in. And so this has been a very unique crisis, both from a healthcare perspective and financially. I've not seen anything like it in my 30-year career, obviously. And I would subject that healthcare providers, and something we've been trying to get government policymakers to recognize more and more, is that healthcare providers have had somewhat of a double whammy here. As most of you know, in the United States, restaurants and bars are shut down. And when that happens, it's not good for them, but the owners can lay off all of their staff and hunker down and try to pay the rent. We're really not in the same position. We don't have the revenue, just like the restaurant and the bar doesn't have the revenue, but we still need to maintain services because we have a duty to provide emergency, at a minimum, urologic care to the community. So this has been a particularly challenging crisis for us. In talking in more detail about the financial impact on urology providers, and I say this for our international colleagues who may not be as aware of what's going on here. The United States has this patchwork of policies based on geography because we're a very large country. So the impact financially varies by geography. Some states have so-called stay-at-home policies, very similar to what's gone on in France and Italy, and other states have had very little of this. For example, in our state of Ohio, we've had, notwithstanding the fact that we don't have the cases that New York has at all, we have one of the most draconian shutdown policies in Ohio in the United States. And so this has had a severe financial effect on our practice and on our area. I know anecdotally that Missouri, for example, another state not represented on this panel, has not had a restriction on surgery or healthcare services in the United States. So I would expect those practices to be much more intact. So my first point here on the financial impact is that at least in our country, it really varies by region. Since we're such a large country governed by this federal system of a patchwork set of policies state by state. I would also point out that the financial impact varies by type of practice. And U.S. providers are aware of this, perhaps international urologists less so. But about half the urologists in the United States have private businesses, independent practices, we call them, and the other half of the urologists are employed by institutions. So the impact is going to depend on their type of employment. I have only anecdotal data on the financial impact this has had on urologists employed at institutions. I do know in our area certain hospital-employed physicians, if not urologists, then other specialists, have seen pay cuts anywhere from 20 to 70% based on declining hospital volumes. On the other hand, I have contacts all over the country, and I know that, for example, at the Cleveland Clinic, they've seen no pay cut. At the Mayo Clinic, they have seen a pay cut. So I think it very much depends on the underlying financial strength of some of these tertiary care institutions as to what's going on financially for the employed urologists. The non-employed, or meaning independent practices, are small to medium-sized businesses that do not have cash reserves such as these large institutions. And without revenue, many of these are struggling to keep their doors open or to pay their urologists. I would then move on to our individual experience, and I would submit this may be representative of many independent practice experiences in areas that have seen shutdown orders like we've seen here and many states have seen. Our group is a large urology group. We have 35 to 40 urologists. We provide over 60% of the adult urology care to a metropolitan population of 2 million lives. It's not New York, but it's still something significant. We have pretty good metrics in our practice. Our clinic patient visits are down by 50%. We have the largest independently operated outpatient urology center in the United States, possibly in the world, and our cases are down by 75%. We're doing only so-called emergency cases, the definition of which can be a little bit tricky. We have our radiation center. The treatments are stable because those build up from the past, but we expect, as we're not doing any prostate biopsies now, that those cases are going to really go down, and that's going to be a delayed financial impact a couple of months downstream. We have our own pathology and laboratory services, and that volume is down by 75%. The only reason we have any volume there is due to urine studies. because all of our tissue pathology has been basically shut down. We do operate a specialty pharmacy in our practice to prescribe oncolytics, particularly oral oncolytics. That business is stable. Those patients still need their prescriptions. We have pretty sophisticated modeling, and I'll get into the next couple of slides some of the measures we've taken. We believe that we're operating at a moderate cash deficit right now, not a disaster, but a moderate deficit despite pretty draconian steps we've taken that I'll outline. And I do want to wind up soon. I just have a couple of other slides left. I would emphasize to all groups that are listening that if you're able to do these three things, you'll be in much better shape than if you're not. And that is to accurately track your daily activity across your service lines. Not easy to do if you haven't previously been doing that. And then to create a model of the impact of that activity reduction on cash flow, which we did quite rapidly at the beginning of this crisis. And finally, perform something that the financial people call a 13-week cash flow forecast, so that you understand whether you actually run the risk of running out of money and not making payroll. So those are the three critical steps that practices need to do. And then once doing those steps, the levers to try to impact your financial health, some are outlined on this slide. I know some practices that have completely shut down. I think we should resist that temptation. As you'll see on the next slide, we need to right size, but all revenue is helpful at this time. So we have not completely shut down. We have emailed our patients to tell them that we are open, particularly for telehealth, as on the third bullet. And in the United States, and I think Dr. Loeb, I saw, has some slides on telehealth as well. The United States government has temporarily allowed telehealth services. This is in existence through September. I think a lot of doctors are getting addicted to telehealth. It's a great thing, but from a financial perspective, I tend to doubt whether the government is going to allow this in metropolitan areas. It's previously been allowed only in rural areas beyond the crisis, but we shall have to see. Our group implemented telehealth as soon as patient visits began to decline, and that represents about 20% of our visits at this time. And then we have been very aggressive on cost saving, particularly payroll. As harsh as it sounds, it's imperative for practices to survive through this, to right size their workforce. And we have placed 58% of our staff on furlough. We have covered their health insurance expenses. So we don't want them in the midst of a health crisis and have no health insurance. We don't think that would be right. But we have furloughed a large portion of our staff. And we have aggressively reduced discretionary spending, not only for what we're doing right now, but for the rest of the year in terms of winding down marketing activities. And we've even gone so far as to cancel our holiday party, which costs us, believe it or not, around $50,000 for 500 or 600 people to get together at the end of the year. And we've already said that this is not a year we're going to be able to sustain those kinds of expenses. Another coping mechanism that we can touch on if we have more time is to take advantage of government resources. I think the detail is beyond the scope of this discussion. In the United States, there are two main programs. There's the Paycheck Protection Program, administered through the Small Business Association, and then there is a series of grants, which is called the Public Health Social Services Emergency Fund. I think I'll stop there and allow others to go forward.